Hi, my name's Dr. Daniel Swan, and I'm a professional services veterinarian with IDEXX Laboratories. I look after Queensland and the Northern Territory, and my job is basically to help educate and increase confidence in the use of diagnostics. Today I'm going to be talking about some of the newer offerings from IDEXX and how we can utilize them in everyday clinical practice. Let's start with the IDEXX CBC. We're all familiar with the comprehensive five-part differential report that we've been receiving from IDEXX, but now we've included some extra parameters that you may not be familiar with. The first is an absolute reticulocyte count with every CBC run, both in clinic and at the reference laboratory. The second is reticulocyte hemoglobin, which you will get results from the ProCyte and from the reference lab. A simple analogy I like to use when describing why we do our hematology to our clients is it's like the check engine light in our car. We are getting an opportunity to take action at this point in time when we know that there's a deviation from health, instead of waiting for things to really break down. Now, there are obviously some limitations to what a CBC can tell us. Rarely does it tell us the absolute diagnosis for why our patient is unwell, but it does give us that objective information so we can identify any deviation from health in our patients and give us an overall general status of the health of our patients. It's also great for trending and to characterize the severity of our patient's disease. And it helps us to monitor the progression of our patients. Are they getting better or are they getting worse? Do we need to do more diagnostics? Are they ready to go home? These are all great examples of the type of information that we can get from just a simple CBC. Let's unpack the CBC just a little bit further. We break it into three parts: the red blood cells, which are our oxygen-carrying cells; our white blood cells, which are our cellular defense mechanisms against both infectious and non-infectious threats; and then our platelets, who play an important role in hemostasis. So this is the typical way that we're going to present the information from a CBC to you in a report. So we break it down into the erythrogram, or the red cells, the leukogram, which comprises the white blood cells, and then the thrombogram, which is on the bottom and is the platelets, essentially. Now, the only difference that you might see in your clinic is that the reticulocyte hemoglobin is only being reported from the reference lab and the ProCyte at the moment. So you may not see that on your report if you've got a laser site. Also, currently, the reticulocyte hemoglobin from the reference lab is being tacked onto the bottom of the report, but in the coming weeks, it should find its way back to where it should be under the absolute reticulocyte count. Now, normally I would go through each one of these parameters and give you more detailed information about it. So what I would encourage is, if you have questions about any of these reported results, then just reach out to me via email or via telephone, and we can talk our way through it. If you have questions about individual cases, though, I would say probably best to contact the IMC team or the internal medicine consultant team. And you can access them from VetConnect Plus or just by calling the 1300 number. So what is included in a complete CBC or a CCBC? The data, the dots, and the cells. Those are the three things that we need to consider. So the data is the number from the hematology analyzer, so essentially our results. The dots are something that we should always look at when we are using our in-clinic analyzers for hematology. It's not something that I would ever skip, because it's really going to help to confirm what our data is telling us. And then if there's any doubt at all in either one of those data or dots, then we should always look at the cells, and that should be done by a microscopic blood film. And if you're ever in need of help, you can always reach out to the internal medicine consultant team, and they can see the results on VetConnect Plus and talk to you either over the phone or via email, depending on your preference, and we will always support you where we can. So let's unpack that reticulocyte hemoglobin that I mentioned earlier. So we all know that hemoglobin is responsible for carrying oxygen. Well, hemoglobin is very much reliant on iron in order to do that one job. You've got one job, red cell, and that's to carry oxygen. And all stages of a red blood cells have this hemoglobin, and that includes those reticulocytes. And reticulocyte hemoglobin is just the concentration of hemoglobin in the reticulocytes. I know, crazy. So the reticulocyte hemoglobin is going to be a very sensitive indicator of iron availability. And we'll go into why that is the case in a second. So this is a little depiction of why iron is so essential in our body to make hemoglobin. When our bone marrow has plenty of iron to make these red cells, it can make these big, robust red cells. But when iron is limited, it's going to make these smaller little cells with less hemoglobin. And the reticulocyte hemoglobin also decreases when iron is limited. So the reason why this reticulocyte panel is so exciting is because all red blood cells contain this hemoglobin, even the reticulocytes. And reticulocyte hemoglobin is a measure of the hemoglobin content in the reticulocytes. So these cells represent what happened in the previous 2 to 3 days. It's the most sensitive and specific indicator of iron availability, and changes are observed much sooner than you're going to see them in the red blood cell indices. The two most common conditions that result in decreased reticulocyte hemoglobin are active inflammation and blood loss. Reticulocyte hemoglobin is a screening tool for insufficient availability of iron for red cell production in the bone marrow. There are two causes of insufficient iron. The most common situation when decreased reticulocyte hemoglobin is reported during active inflammation. A non-specific defense mechanism against invading organisms such as bacteria or viruses is to sequester and restrict the availability of iron to possible infectious agents. However, developing red blood cells are just an innocent bystander in this situation. Providing supplemental iron will not be of any benefit and should be avoided in this situation because it will build up in other tissues like the liver and then cause additional problems. The other primary cause for decreased reticulocyte hemoglobin is bleeding. Specifically external bleeding where the blood is lost from the body and takes the iron along with it. This causes a true iron deficiency. So if bleeding is internal, iron may not be lost from the body, and in this case, iron deficiency does not develop. So the three important features of reticulocyte hemoglobin that you should be aware of. One, it's a sensitive and specific biomarker for iron availability. Two, it's an earlier indication that there's a problem. Mean corpuscular volume and mean corpuscular hemoglobin concentration require time for changes to be evident, weeks in fact. Reticulocyte hemoglobin changes occur in 2 to 4 days along the timeline of a reticulocyte production. Finally, it's a measure of both functional and absolute iron deficiency. While reticulocyte hemoglobin does not differentiate between inflammation and bleeding, it will again alert you to investigate for the root cause. Let's move on to C-reactive protein. Now, this is by no means a brand new test. It's actually been around in the human medicine world for a very long time, but it's only been the last few years that it's made its way into veterinary medicine, and even more recently to the reference lab with IDEXX. C-reactive protein, or CRP, has been available on the Catalyst for quite a while now, but has only recently become available at the IDEXX Ref Lab. Now, I will reiterate that it's a canine-only test, so it's not going to have much diagnostic value at all, or any value at all, in your feline patients. So what is C-reactive protein, or CRP? It's an acute phase protein that's highly sensitive and specific for systemic inflammation. Now, it's made in the liver and it's stimulated by cytokines. So when we have an area of inflammation, those macrophages and monocytes are producing cytokines. And as that inflammatory response worsens, those cytokines spill over into the systemic circulation, and they stimulate the liver to produce these acute phase proteins, one of which is CRP. Now, as I mentioned before, those cytokines released by the monocytes and macrophages trigger the liver to produce various acute phase proteins, one of which is the CRP, or C-reactive protein. The acute phase proteins help regulate the immune system, but little else is known about them, except for the fact that they are elevated when we have systemic inflammatory responses. So now that we know what CRP is, why would we use it? And the main areas that I would use it would be to detect and characterize the severity of any systemic inflammatory response, but also to monitor progression of our patients as we follow them through hospitalization or through treatment program. And it also helps with prognostication because this is a great objective way that we can relay information to clients as their patients continue their journey through our care. Now, the great thing about the utilization of CRP in our patients is that it's so sensitive to inflammation and it has a really short half-life. So we're going to see increases about 5 hours after the initial stimulus, and then we're going to see improvements as early as 24 hours after that inflammatory response starts to resolve. In a lot of cases, systemic inflammation starts as a localized area of inflammation. A great example is a prostatic abscess, where we have a localized infection in the prostate, but then as that infection worsens, the inflammation worsens, we have a spillover of the cytokines from that local area into the systemic circulation, triggering the liver to produce acute phase proteins like CRP. So let's talk about a few general areas where we might be able to utilize CRP in everyday clinical practice. The three areas in everyday clinical practice that I can see utilization of CRP being useful would be those sick off-color patients. You can't put your finger on what's wrong. Physical exam findings are fairly unremarkable. Maybe the rest of your diagnostics are relatively unremarkable. Maybe you want to differentiate between an inflammatory leukogram and a stress leukogram. A CRP might help give you extra confidence to go further with your diagnostics if it's abnormal. The second is monitoring for post-operative complications. And a great example of this would be monitoring and trending your CRP from day 1 to discharge for your foreign bodies. So dogs that have eaten something that they shouldn't, and you've done an enterotomy. If you're seeing a spike on day 3 or 4, that's going to give you a lot of confidence to go further with your diagnostics because maybe you've got a breakdown of your enterotomy site. And then finally, monitoring treatment efficacy. And there's actually a papered study that was published in 2017 that followed dogs that had bacterial pneumonia. And what they found is that by trending and monitoring CRP and basing the duration of antibiotics on CRP, they were able to significantly reduce the duration of antibiotic treatment without increasing the number of relapses that they had. So that's really exciting for our antimicrobial stewardship. So this is that study that was published in the Journal of Veterinary and Internal Medicine in 2017 that followed the 19 pneumonia dogs and 64 healthy dogs. And CRP was able to guide the duration of that antibiotic treatment and significantly decrease the length of antibiotic treatment versus the standard period without increasing relapses. Let's quickly go through a few other details related to C-reactive protein. Our C-reactive protein is going to be a more sensitive indicator of active inflammation than a CBC. And the reason behind this is that our CBC, especially our neutrophils, can be reduced and consumed faster than they can be produced in severe inflammatory reactions. Our CRP is also independent of our neutrophils and white blood cell dynamics, and it's not going to be complicated by the use of non-steroidals, corticosteroids, or epinephrine. Now, if non-steroidals and corticosteroids are doing their job, I feel like we will see a reduction in our CRP, but they're not going to complicate the production of those acute phase proteins. Now, a CRP does not diminish the importance of a CBC. As we spoke about earlier, the CBC is an essential part of the minimum database, and really we cannot make an adequate diagnosis in a lot of cases without our CBC. A question that you might have is, if these acute phase proteins are produced in the liver, what if we have a compromised liver or compromised liver function? Is it going to affect the production of these acute phase proteins? And the answer is no. We're still going to have a reliable production of these acute phase proteins, even if we have a compromised liver. It's also not going to be affected by total protein. Now, there are a few factors that are going to affect our CRP. Puppies less than 3 months of age are not very good at making acute phase proteins, and they just can't generate them as well as adult dogs. Serious exercise in dogs can also increase your CRP, so I'm thinking race dogs more than sled dogs. And then finally, miniature schnauzers, they have a slight increase, less than 2 times normal, but you can still utilize CRP in this breed, but I would definitely use it as a trend, and I wouldn't rely so heavily on a single result. So there are some test factors that we need to consider when we're running our CRP. Now, I've said it once and I'll say it again, this is a dog-only test. There's going to be very little to no diagnostic value in running this in your feline patients. It's an immunoassay, and the reason why I've put that in there is because with any immunoassay, we're going to get what's called assay variation. And what I mean by that is if you run the same test on the same patient on the same day, even using the same sample, you might get some mild variation in the results that you get. Now, you can run CRP both on serum and plasma or LithHep samples. You can add it to any profile, or you can use it as a standalone test. It has a dynamic range of 1 to 100, and you can do dilutions if it's outside of that 100 range. So to summarize CRP, or C-reactive protein, best used in those sick off-color patients to monitor for post-operative complications and to monitor treatment efficacy. So when to stop those antibiotics, that's really important for our antimicrobial stewardship. Now, I'll briefly talk about SDMA. I think by now everyone who has used IDEX is familiar with SDMA, but one thing has changed, and I'll just note that really quickly. So the main change in SDMA is that from September 2019, IRIS has adopted it into their staging guidelines for chronic kidney disease. So let me know if you want an updated IRIS guidelines. I can send you a soft copy of the pocket guide, and I can send you out a hard copy if you need one. So the IDEX microbiogram came out in 2020, so this year, and it's really exciting because it's going to help veterinarians with their antimicrobial stewardship. You'll find this on page 59 of your directory of products and services from IDEX, and it's got this little QR code that you can scan with your phone. And I would suggest that everyone should sign up for it because it's free. The only thing that you do need to do is submit 10 samples, and that's ears or urine, per 6-month period. And essentially, I'll go into more detail about why that's important in a second, but that's so we can give you statistically accurate results when we're reporting this microbiogram to you. This is a mock-up of what that microbiogram report is going to look like. And it shows you why it's so important to send in those 10 samples in that 6-month period, because not only are we giving you state and national data, but we're also giving you data specific to your clinic for the most commonly isolated organisms and what antimicrobial agent is going to be the most and least effective at treating them. Thank you so much for watching this presentation. I wish that I could be there in person to go over this and answer your questions in real time, but given the current COVID-19 situation, this is the next best thing. Feel free to email or call me anytime, and we can organize a time to go through anything that you have questions about. There's a whole lot more that's being offered from IDEX and more tests coming in 2020. So stay tuned, and I look forward to meeting you all in person soon.